We'll go ahead, ma'am. I think sir will log in, ma'am.
Please, ma'am, please.
Okay. Good evening, everyone. A warm welcome to one and all for our episode called as Vivaadham. This is a webinar series where we'll be focusing on a single topic and we'll be focusing on the plus and minus of the topic, how we have evolved over a period of time to the new one, or how whether the old one still holds good in clinical practice. So this episode is Vivaadham episode number 6. So the topic today is endometrial receptivity array in recurrent implantation failure. And we all know that recurrent implantation failure is always a very annoying experience, both for the fertility consultant as well as for the couple. So when we are evaluating, there are a lot of tests or a lot of evaluation that we do in case of RIF. So one of them seems to be what is called as endometrial receptivity array. Today, we have stalwarts talking about endometrial receptivity array, whether it's a boon or a bane. And we have an expert moderator, Dr. Ramaraju, who will talk about the pluses and minuses and how we have to adopt it in clinical practice on a day-to-day basis. A warm welcome to one and all once again. I'll share my screen first. See? Yeah. We have, I welcome President Dr. Sampath Kumari Madam, who's a professor and HOD at Sri Muthukumaran Medical College Hospital Research Institute, Foxy Vice President 2012. And Madam is very dynamic and very enthusiastic about academics and all other extracurricular activities. Madam, over to you, Madam, for the welcome address.
Yes. Good evening to all. I welcome you all for this important Oxy Vivaadham series. I think this is our 6th program. Every month we are conducting one. As Karpakambal was telling, it is not a debate. We are telling about what is existing and how the new one has evolved. For this, we have an expert. That is the moderator. Now we have Dr. As she told, today's topic is endometrial receptivity array, whether it is a boon or a ban. We have Dr. Swati and Nityasri and the moderator being Dr. Ramaraju sir. Ramaraju sir, hope she has joined. Welcome, sir. Now we will go with the scientific session. I'll hand over the mic to Dr. Karpakambal. Karpakambal, thank you for conducting this program very sincerely with Dr. Vijaya, who is the other co-moderator, and our secretary, Dr. Amina Mahalingam. And thank you, Karpakambal. We'll go with the scientific session.
Thank you so much, Madam. We have Amina, the Oxy secretary, and Vijaya Madam also, who was a chairperson of the Medical Education Committee of Oxy, who has joined us. Vijaya Madam is our
prayers also.
Prayer பண்றீங்களா ஒரு வாட்டியும்
இல்லையாமா?
Okay, Madam. We'll go ahead with the sessions, Madam. Now
you go with the session. Concluding வந்து Vijaya.
Okay. Now we have Dr. Swati, who's going to talk about endometrial receptivity array in RIF as a boon. So over to you, Swati. Swati is a professor at Sri Ramachandra Medical College Reproductive Medicine Unit. Over to you, Swati, for your inputs.
Yes, ma'am. Thank you, ma'am. Ma'am, it's seen, ma'am, my screen?
Yes, ma'am.
Okay, ma'am. Good evening, everybody. I'll be presenting today on endometrial receptivity array. Is it a boon? So what is endometrial receptivity? So endometrial receptivity is the period of endometrial maturation when the lining acquires a functional state that allows the embryo adhesion and implantation. The receptive endometrium is time-limited, progesterone-dependent phase of the endometrium during which implantation can occur. The window of implantation is a transient period when the endometrium is conducive to the blastocyst acceptance and implantation, usually observed 6 to 10 days after an LH surge or approximately on day 20 to 24 of a regular 28-day cycle, and it lasts for around 24 to 48 hours. So we all know the steps of human implantation and decidualization, which goes by apposition, adhesion or attachment, invasion or penetration by the blastocyst, and then decidualization. So what are the factors which influence the endometrial receptivity? There are many factors like growth factors like insulin like growth factor 1, heparin binding epidermal growth factor, transforming growth factor beta, vascular epithelial growth factor, and cytokines like leukemia inhibiting factor, which plays a major role in implantation and endometrial receptivity, colony stimulating factor known as the granulocyte factor, interleukin 1, and many genes like the HOXA, bone morphogenetic protein, and WNT4, and proteins like mucin 1, glycodelin, matrix metalloproteinases as well. So, what is transcriptomics? So, transcriptomics is the study of gene expression. The transcriptome of the human endometrium, that is the clustering of genes, were identified into 4 groups, and they were comparable with the histological phenotypes of proliferative, early secretory, mid secretory, and late secretory. At a molecular level, the pre-receptive or the early secretory phase is characterized by increased metabolic activity in preparation for the implantation. The receptive phase will witness something called a transcriptional awakening, where there is upregulation of the gene expression. And this involves the metabolic and secretory activity, and also there is activation of the immune response. So the rationale of why ERA came into existence. The endometrial factor plays a key role in implantation. So ERA is a test which determines when the endometrium is receptive, that is the narrow window of implantation. So mainly in people with RIF, that is a recurrent implantation failure, studies say that they have a displaced window of implantation when compared to the general population. So the endometrial gene expression signature, this allows evaluation of the endometrial receptivity when we can do that by identifying and transferring in a personalized window of implantation. So this group, iGenomics, came into existence in 2011, and they were the first creators of ERA. So by them, the endometrial receptivity array or analysis, it determines the optimal time in the endometrial cycle to perform an embryo transfer. So the ERA can increase the chances of pregnancy by synchronizing an implantation-ready embryo with a receptive endometrium. So what are the indications of ERA? So patients with recurrent implantation failure, patients with BMI more than 30, patients with thin endometrium, patients with adenomyosis, and even recurrent biochemical pregnancies. So studies say that in all these conditions, there is a displaced window of implantation, and hence it may be suitable to do ERA in this population. So ERA now uses next generation sequencing. Earlier it was using CGH, that is comparative hybridization microarray, but now after 2017 all the studies they use next generation sequencing technology to analyze the expression of 248 genes related to the endometrial receptivity status. The results from this test are based on the expression analysis of these genes with a computational predictor designed and developed by iGenomics. And after sequencing the genetic material, that is the RNA from the endometrial biopsy, the endometrium is termed as receptive or non-receptive. So the endometrial biopsy, how is it taken? First, the cervix is cleaned with a sterile dry gauze, no betadine. You need to label all the patient details in the tube. The tube will be provided by the iGenomics company. Then sample is taken by a Pippel, and around 70 mg of tissue, that is up to this white line on the tube, till there the tissue should be there. And you should avoid blood or mucus. And once you put it into this tube, you have to shake it for 10 seconds. This is done to make, there will be a fluid provided in the tube, and that will help the RNA disassociate from the tissue and stabilize the genetic material. Then we store it in the fridge for 4 hours at least to stabilize it. And after that, it can be shipped even in room temperature. But if it is going to be very heat climates like in India and all, then it's better to ship with a cold gel pack. So we're taking a biopsy, then there is RNA extraction, then next generation sequencing analysis done, a report is given, and then the transfer is planned according to this report. So when do we take the biopsy? To enable reproducibility of the results, ERA test must be performed under identical conditions and a subsequent embryo transfer cycle. So it will be in a HRT cycle. So after 5 full days of progesterone, that is P plus 5, 120 hours of progesterone administration, the ERA biopsy is taken. If you're running a natural cycle, then from HCG plus 7 it is taken. So after a receptive report, we will transfer a blastocyst at either P plus 5 or for day 3 embryo 2 days lesser. So P plus 3. So here we can see, for example, in igenomics, they've given this where after when endometrium is ready, you feel when it is above 6 mm, they're saying. And when you're giving the progesterone, that is taken as P plus 0, 5 days from that. So on this day, P plus 5, that is at least 120 hours of progesteronization, a biopsy is taken. The results will come either like receptive, post-receptive, pre-receptive. So receptive means your gene expression profile is concordant with the receptive endometrium. So you transfer the blastocyst following the same protocol and timings like as in the ERA test. Post-receptive means the gene expression profile has already passed the receptive stage. So though they recommend in igenomics that a second biopsy is needed, we don't follow that. We can just plan 24 hours earlier. And for pre-receptive, meaning the endometrium is in a pre-receptive stage, these patients may need additional 1 more day of progesterone before transferring. And when it comes as proliferative, that means the endometrium is proliferative stage, it's showing like it is not exposed to the progesterone. So either whether the patient is taking the injection correctly or the biopsy is done correctly, timed correctly, all this has to be checked. So this is how the ERA example report. So it will come like pre-receptive, receptive, post-receptive. Here the triangle marking is showing post-receptive. That means the endometrium is already gone beyond the stage of receptivity. So when next cycle, when we are preparing for the patient, so 1 day before, earlier, so when the report is post-receptive, 24 hours earlier to that is when we need to do the transfer. So reproducibility of the results, it is saying that they're proven to be reproducible for at least 36 months, mainly when the endometrial preparation should be replicated in the same way and there should not be much of a difference in BMI in that 36 months. And intervention at uterine level, we shouldn't do ERA and then go do myomectomy or endometriosis surgery and then go. So all that will alter the endometrial status. So why ERA now? So this study in Valencia, Spain by Jimeno et al., they came up with the ERA. This study was the first study came out in 2011, published in fertility and sterility, was a validating tool for ERA. So by this study, they said that this ERA is a diagnostic tool and can be clinically used in reproductive medicine. So initially it consisted of the microarray, like we said, in 238 genes ERA was studying. So in this sample size, this was the study in which validated ERA. And they found that transcriptic signature, that is 134 genes in which 74 were upregulated and 60 were downregulated. And they said that this tool is 99.7% sensitive and specificity around 88.6%. But what does the evidence really say in regards to ERA? So in a study by Dr. Nalini Mahajan et al. Published in Delhi, so this is in an Indian population. This was one of the earlier studies which came in 2015. And here it was retrospective study. They examined 186 infertile women and they classified into 3 groups based on results with recurrent implantation failure, 1 previous IVF failure and thin endometrium group. And here they found something interesting. They found that the non-receptive endometrium in the RIF group was 27.5% and previous 1 IVF failure group was 15%, and this was statistically significant. And the pregnancy rate when they did a personalized embryo transfer came up to 42% in the RIF group. And this was comparable to their pregnancy rates in their hospital, even in previous normal IVF cycles without the RIF group also. And then they did a subgroup analysis of only RIF patients in their hospital alone, 33 patients. They found that 39% of that was non-receptive. And when they underwent a personalized embryo transfer, after correcting the WI, that is the window of implantation, 50% of them conceived. And they also analyzed a thin endometrium group, which found that though the endometrium is thin, 77% are receptive. So it does not mean when there is thin endometrium, patient is always non-receptive. So this was a plus point in that. So to conclude, in this study, 27.5% women with recurrent implantation failure showed a displaced window of implantation, and their pregnancy rate, ongoing pregnancy rate, and implantation rate improved after a personalized embryo transfer. Next came a study in 2018 by Tan et al. So this study published in Journal of Assisted Reproduction. They analyzed 88 patients retrospectively, and all of them who underwent a embryo transfer. In their study also, they found that 22.5% had a displaced window of implantation diagnosed by ERA, and they qualified for a personalized embryo transfer. And after doing that, it was found that the implantation and ongoing pregnancy rates were statistically higher, that is 73% and 63% respectively, compared to their patients without a personalized embryo transfer. So here we can see the blue bars are all the personalized embryo transfer. And though the p-value is not statistically significant here, it was better compared to their standard embryo transfer. And even in a recurrent implantation failure patient here, their personalized embryo transfer, the blue bars, were all their implantation, ongoing pregnancy, and live birth rates were all better than their counterparts. So ERA has a capacity to offer an individualized approach. Even this study proved that. Next came a study by Simon et al. In the same hospital that Valencia, Spain, where they created ERA. They did a 5-year multi-center randomized control trial and they published this in 2020. Here, 458 infertile women were analyzed and divided into 3 groups. The personalized embryo transfer group, frozen embryo transfer group, and fresh embryo transfer group, and their outcomes were studied. Here, they included women less than 37 years and normal BMI, normal reserve. And in this study, they excluded RIF patients. So what they found that in this table, that is the intention to treat analysis, in this group, they found that the pregnancy rate in the personalized embryo transfer group compared to the fresh transfer and frozen transfer, pregnancy rates were better, 58.9. But here in the intentional to treat analysis group, p-value was not statistically significant. But an interesting thing, their cumulative pregnancy rate, so the next transfer, next transfer, but women who underwent a personalized embryo transfer, there the p-value became statistically significant and their outcome was better. Next, they analyzed by the per protocol analysis, that is all the patients who stuck to the protocol and did not fall out from that. They found that the pregnancy rate and implantation rate were statistically significant when it followed, and also the cumulative pregnancy rate and live birth rate was statistically significant comparing the personalized embryo transfer with the frozen or the fresh transfer. So they concluded that statistically significant advantage is seen for personalized embryo transfer in cumulative pregnancy rate as well as cumulative live birth outcomes when compared to fresh and frozen. And next study published by Ohara et al. In 2022 in Japan. So this study here, so till now we saw ERA with 238 genes. Now this test by this company Cooper Surgical, they produced something called the ERA peak or the ER peak, where this analyzed only 48 selected genes by the RT-qPCR. So here they analyzed recurrent implantation failure patients in 2 Japanese hospitals, and what they found out that the clinical pregnancy rate and live birth rate of the personalized embryo transfer group were significantly higher than their non-personalized embryo transfer group. As we can see here, even before propensity score matching, that propensity score matching is to remove any bias. So even before that, it is statistically significant. And just to make sure that the bias is removed, they did a PSM. And even after that, they're proving that the clinical pregnancy rate and live birth rate was statistically significant. They also did a subgroup analysis between women of advanced maternal age and non-advanced maternal age. And it was found that in advanced maternal age group, their clinical pregnancy rate was 34.1% after doing a personalized embryo transfer. So even in older patients, it is crucial. And next came a study in 2024 by Li et al. In China. So this is even more advanced. They did something called as RSERT, that is RNA sequencing endometrial receptivity test. This analyzes 175 differential genes. So this came in 21 and Chinese studies in 2024 were published. And here they studied 155 patients with recurrent implantation failure. And they found that in recurrent implantation failure, 60% of them were non-receptive endometrium. So after correcting the window of implantation, when they went for a personalized embryo transfer, the pregnancy rate was 43.8%, which was statistically significant. And then we come to a study in 2025 published by Zhu et al. This study shows the clinical efficacy of the endometrial receptivity and other factors which influencing the window of implantation. This was done in China for 4-5 years and then published in 25. So here they analyzed 3,605 patients, and here they found that in 782 patients who underwent ERA, 401 had a displaced window of implantation. So here we can see this orange bar compares non-recurrent implantation failure with personalized embryo transfer compared to people with non-personalized embryo transfer. They found that the clinical pregnancy rate and live birth rate in both the non-RAF group and RAF group were significantly better when they underwent a personalized embryo transfer compared to a just embryo transfer. And they also found that the displaced window of implantation increased gradually with the increase in age group. Here we can see as the age is above 35, there was 61% of them had a displaced window of implantation, also emphasizing the importance of age in these patients. So to conclude, ERA is a valuable diagnostic tool and it is important to individualize for who we are going to do it and identifying a personalized window of implantation, especially useful for patients with recurrent implantation failure. So evidence from retrospective and randomized control trials are saying that personalized embryo transfer does improve pregnancy rate and live birth rate. So when we follow one size does not fit all for everybody, same way even the endometrium for everybody, the window of implantation cannot be the same, especially in RIF patients. So timing does matter. ERA shows that in a meaningful fraction of RIF, the window is not where we think it is. And when we aim at the right R, we hit. So ERA, I would say, is definitely a boon in a selective population. Thank you.
Thank you so much, Dr. Shweta. No, you have highlighted all the studies from the past to the present this year.
Yes,
Now,
ma'am.
over to you, Dr. Divyashree. Divyashree is a consultant, fertility consultant at Genia Fertility Center. I just show her CV, and she is once again, she's a rising star. She has received the Rising Star Award and a very dynamic speaker and dynamic clinician. Over to you with Divyashree for your inputs on why ERA has not stood the test of time.
Okay. Thank you for the opportunity, Dr. Karpagam, and the society. And also thank you, Dr. Shweta, for that detailed session on ERA, why it is required. Can the people see my screen?
Oh, I mean, your PPT is not seen. You can open your PPT. Open your PPT now.
Yeah.
Yeah, you can make it full screen. Yeah. Done.
So
Okay,
today
go
I'm going to, today I'm going to talk about endometrial receptivity array, unmasking the bane within the endometrium. Outline of today's talk: what are the number of genes which are tested, array versus sequencing, method and timing of biopsy, the progesterone effect, what percentage of women might need the ERA test, ill effects of embryo cryopreservations, and lessons to learn from studies, and finally summary and conclusion. These are the pitfalls what I have noticed with ERA, which I am going to share with you today. Let's get started with the number of genes tested. It is not just the iGenomics group in which 283 genes are studied, which is commercially available. Initially, even they came with 236, and then it became 238. But way back from 2008, initially 63 genes were studied. There are other endometrial array studies also, which have studied 236. 2017, they studied 303. 2017, they studied 16, and the same group studied genes in relation to HCG plus 7 and LH plus 9. So in that, mind you, they have got different sets of genes again, 218 and 133. If it is natural cycle, it is different. If it is stimulated cycle, it is different. So this is what I want you to understand. So the number of genes which are studied is not constant. So there is, even though we say it is a transcriptomic signature, it is not constant. It could be as less as 63 and it could be as high as 616 genes that we are going to study. So when it comes to the number of genes which are tested, various pathologies have been found in endometrial biopsies. Histological dating alone lacks the sensitivity to identify a definable defect in endometrial development and implantation process. And most importantly, the dating is not the only reason for implantation failure. We have to understand that. So, as I told you, there is no uniformity in the number of genes which are studied. When it comes array versus sequencing, I think Dr. Shweta also mentioned this. We have now moved on to sequencing. So all the past and current studies using array technology might not be accepted as accurate anymore. So whatever data we have got from the previous studies or yesteryear's studies, that may not hold good now. because it was through array, and now NGS is said to be the gold standard. NGS is more comprehensive in coverage and precise in quantification of global gene expression profiles. Hence, all the studies on the era which have used array test becomes difficult to interpret and should be re-evaluated based on NGS. This is something that we should all understand. Now, most importantly, the method and timing of biopsy and endometrial correction. What we do, biopsy is a blind procedure. All of you agree with me. The manual procedure of endometrial cells it's a manual procedure where the endometrial cells are collected. We use people, but this may result in variable amounts and depth of cell collection. Whatever genes which we are studying is not just the endometrium. There are glands which express genes. There are stroma which is going to express gene. So depending on how much of stroma and epithelium that we get, the gene expression could also vary. That is what you should understand. And for this, they came out with a correction factor called computational deconvolution. If we cannot consistently identify the ovulation, so that's about computational deconvolution. I think it is out of the scope for today's talk to speak about it because it is a statistical jargon or a terminology which is involved with the statistics. So, but again, it is not going to be absolutely right or blindfold. And one more thing is, if we cannot consistently identify the ovulation, then the timing of biopsy and the gene profile might be skewed accordingly. So how do we exactly know, okay, this is the LH peak? Or how do we exactly know this is the progesterone? Let me tell you, when you give progesterone to your patients, you tell them you start progesterone from tomorrow. You identify when did they start? Do they tell you the truth also? So many times they may forget, or they may some woman may start, if she's early to bed and early to rise, she may start at 6. The other woman, she may start at 12. So already, you cannot say, okay, this is the exact time that you have started. Okay, now you can also tell me that we tell them that yes, you have to start at this point of time only. You have heard about endometrial hormonal manipulation before ET or any ovarian stimulation or triggering of ovulation affect the gene profile differently. For example, whatever blood levels that we measure, is it right? Is it biologically active? These are the things that we also have to understand. And one more important elephant that we are missing in the room is progesterone. So it is the progesteronization which is going to cause alteration in the expression of genes that we are not even considering. We are only speaking about LH. So when did the progesterone elevation happen is something that we don't know. Even if we tell them, okay, this is where you have to start progesterone in an artificial cycle, what about natural cycle? Or even if you have given progesterone in an artificial cycle, you have heard about first pass effect. So when did the progesterone start rising in the endometrium is what it's not something that we don't know. You may be thinking, why Dr. Diveshri is telling all these things? Because is it so important to even find out all these things? Yes, it is. If you are thinking that ERA is be all and end all procedure, when we are looking at the minute details of plus or minus so many hours and minutes and seconds, these things will also matter. And I'm sure you'll not be able to identify the progesterone exposure. As I told you, the progesterone effect is something that we are missing. It is the undeclared elephant in the room. We are missing an elephant in the room. The main driver of the secretory changes that determine the window of implantation is progesterone. There are complex correlations between progesterone implantation and success rates. We all know that, and I need not have to overemphasize it. Yet, the ERA test was presented independently of progesterone levels. Progesterone alters gene expression. This dictates that any new procedure that is based on gene expression should consider the concomitant progesterone level, not just the LH levels, or not just when you started HCG exposure. Then, as I told you, manipulating the endometrium with such precision, is it really required? Variability in the compliance of progesterone start, as I told you. When did the patient start her progesterone? Did she take intramuscular progesterone? Did she start vaginal progesterone? And the first pass effect of that, the exact level of progesterone in the endometrium, we have never been able to measure this. And most importantly, mind you, LH plus 7 is not always equal to progesterone plus 5. Why such a precision is required in an embryo transfer? Is it so critical? As you know, implantation is a window which is at least 3 days in duration. Serum progesterone levels vary widely because of uptake, absorption, and metabolism. Most importantly, we cannot forget first pass effect. It is a window of implantation and not point of implantation. We are not chasing the point of implantation. We have to consider window of implantation, which is 3 days. We all know. Now coming to what percentage of women might need the ERA test? Let me tell you the Nalini Mahajan study which Dr. Shweta quoted. Here, there were 2 groups. The group 1 was 1 IVF failure, group 2 was 3 IVF failures. When they did ERA and they did personalized embryo transfer, after the first IVF, the success rates, the 15.1% came as non-receptive, whereas with group 2, 27.5% came non-receptive. It's quite starking difference, yes. But then when they did the personalized embryo transfer, don't speak about the percentage. Let us understand how many of them conceived. Only 1 out of 7 conceived in group 1, which is 14.3%. And in group 3, 8 of 18 conceived, which is okay. So if you consider group 1, the overall pregnancy rate with first IVF cycle was 61%, but with group 2, it was 42%, which means overall, we are left with 6.5% of women who did not get pregnant even after 3 failed IVF cycles. So out of the 6.5% of women who did not conceive after 3 IVF cycles, only 27.5% were non-receptive. And so, in a nutshell, only 5% of women who have implantation failure require endometrial receptivity array test. So it is unlikely that a single endometrial cause underlies recurrent implantation failure. We all know most failures are due to the embryo quality. After 3 to 4 IVF cycles, only a few women remain not pregnant. Faulty endometrium is infrequently the cause of recurrent implantation failure. We have to understand this truth. So let's understand a new definition of recurrent implantation failure on the basis of anticipated blastocyst aneuploidy rates across female age. As you could see, overall 4,429 women patients were included. And in this, it is quite self-explanatory that only 5% of them remained non-pregnant in spite of recurrent euploid embryo transfers. So in these patients, probably we may have to look at endometrial receptivity, but it is not just endometrial receptivity array. We cannot say endometrial receptivity is just endometrial receptivity array. There are a lot of interplayers to this. Whatever we are looking, it is just implantation is an orchestra where multiple factors are involved. So we are just studying the transcriptomic profile does not mean we also know about the immune system. We also know about what are the changes which have happened because of hormone exposures. So it is just a tunnel view if you just look at ERA. So the cumulative pregnancy rate after 3 cycles was 95.2%. So in them, if the ERA test, if it has to be done, it should be after 3 IVF failures, will apply only to a minority of IVF failures and not majority. Now coming to, if we have to do ERA, then we have to cryopreserve the embryos. So let's understand what the ill effects of cryopreservation. Yes, I do understand we have come a long way in embryo cryopreservations and cryoembryo transfers. We have achieved very good success rates. But cryopreservation done without indication is not acceptable. Just because we are good in cryopreservation does not mean it is freeze-all for everyone. It's unlikely that a single endometrial cause underlies recurrent implantation failure. Most failures are due to embryo quality, and after 3 to 4 IVF cycle, only a few women remain not pregnant. Faulty endometrium is infrequently the cause. And before this, I also want to highlight, I think it is missing in the slide. We all know when it is compared with the natural FETs or in a fresh embryo transfer, the overall incidence of preeclampsia, intrauterine growth restrictions were much lesser. Especially this was more pronounced with women who are PCOS, where the incidence of preeclampsia was 3-fold when it comes to cryopreservation. So we all know the pregnancy complications of frozen embryo transfers. We cannot ignore that. Now let's learn from studies. What are the lessons learned? These are the two famous meta-analyses which are available. I don't want to put small studies, retrospective, or RCTs with just few sample size. These are the two largest meta-analysis which is available. As you can see, the findings of the current meta-analysis did not reveal a significant change in the rate of pregnancy after IVF cycles using ERA. And this is one more meta-analysis in which they also mentioned that it cannot be it is not going to improve the probability of pregnancy just because we did personalized embryo transfer. And the same thing we presented in ISHRE, where it was quite normal, like almost 25% of them were non-receptive. But when we did personalized embryo transfer, we did not find any difference in outcome. So to summarize, negative pregnancy test is frustrating, both for the patient and the clinician. So just because it is frustrating to us and patients, we are always in the quest of doing something. And even patients are desperate. I would say, yes, they are desperate to do something and want to know something. So that should not be the indication to do the endometrial evaluation. Embryo endometrial crosstalk is what we know all about. It's just the tip of iceberg. What we don't know is a lot, and it is far from understanding and testing. Every measurement of one such effect, it will not give a panoramic view of the whole situation. Most IVF failures are due to embryo issues, and endometrial evaluation is required only in minority of patients. Can you hear me? Hello? Hello?
Yeah, you can go ahead.
We can hear you.
We can hear you.
Because it was coming as unstable connection. So as I told you, endometrial evaluation is required only in minority of patients, and endometrial evaluation does not always mean endometrial receptivity array. We can also look at junctional zone, because most of the time the junctional zones are altered. We can also look at BCL6, but it is in indicated patients where whether it is overexpressed or underexpressed. Endometrial receptivity does not always mean endometrial receptivity array. NGS cannot reliably reflect the full complexity. Yes, we know array CGH is no more now. We have moved on to NGS. Even though it is NGS, it cannot reliably reflect the full complexity of the implantation process without bringing into the equation the different factors that can potentially affect implantation, in which very important is the interplay between the estrogen and progesterone. Let's concentrate on window of implantation and not to chase point of implantation. To conclude, art of medicine, however, includes learning to sit with the discomfort of the unknown. Where we doctors, we are the cream of the society. We don't want to say that we don't know. We always want to say, yes, I know this, I will do this, I will do that. But the art of, or to have the discomfort of unknown, we don't want to learn that art. With regards to ERA, we are in the era of aggressive marketing than science. Even before it was approved in science, because of aggressive marketing, ERA has spread into the world with as if it is the potion for treatment of implantation failure. When it comes to ERA, we have still not entered the era of enlightenment. Thank you for the patient hearing, and I'm open for questions.
Yeah, thank you so much, Divyashri. I know that was very, very clear negatives or why Veera should be tailor-made. Over to you, sir. Vijay, madam, you can introduce Dr. Ramaraju, sir. I will share the screen. 1 second. Vijay, madam?
Yeah, I'm here only. Sir's...
Yes, sir, CVM.
Yeah.
Yes, madam, can you see?
Yeah, I can see, yeah. Sir is founder and the medical director of Krishna IVF Clinic, and he's an emeritus professor of human genetics, Andhra University, and he's an adjunct professor of reproductive medicine in SRMC Chennai, former visiting professor of Justus Liebig University, Germany, advisory board chairman, Merck, principal investigator, Samsung R&D, pioneered IVF ICSI test, vitrification, AA-driven ultrasound, and genetic research, LHCG polymorphism, and he has a research impact, 50% publication, 1,600 citations, and index 18, and Delhi Consensus Member on Receptor Research Global. I think it has gone. Yeah, please show his CV, please. I want to finish that CV.
Yeah, it's there, madam. Can you see, ma'am?
Yeah. He's an educator, trained several clinicians and PG medical students, global reach via online platform. Lots and lots of awards. ISA 25, ACE 2024, TAPISA 2022, Lifetime Achievements Award, Samsung Best Partner Award 18 and 19. So many things he has done and so many things I don't understand also. Such a great scholar. Sir, welcome, sir. And you are the correct person to give the judgment.
Thank you so much, sir. Over to you, sir, for what we should do as clinicians.
Screen sharing is good.
Yeah.
Yeah.
Yes, sir. You can make it slideshow.
Good evening, everybody. Thank you for the opportunity. First of all, both the speakers are right, but in a different context. The first and the foremost is the topic of the discussion is only limited to environmental receptivity array or environmental receptivity assessment. And what is the commercial available test that is available to do environmental receptivity test is the array test, and that's what we are discussing about. Actually, when it is developed, it was developed for recurrent implantation failure, but not for personalized embryo transfer. That's an important carry-home message. In 2011, when Simoni et al. Has released the product as a commercial entity and as a research entity, it was developed for recurrent implantation failure, but not for personalized embryo transfer. That's a key carry-home message. The second thing is, we assumed that it identifies the window of implantation and it distinguishes between receptive and not receptive endometrium, but no publications have come in that it identifies beyond doubt the window of implantation. We took it granted, but we never questioned the status quo that ERA test does not identify completely the window of implantation. And also the receptivity and the non-receptivity endometrium. We took it granted that the test will identify it. That's one of the fallacies in the last 15 years. We took as ERA test is to identify window of implantation, and it will tell receptivity and non-receptivity, and started questioning its validity based on the assumption that it is identifying that. It never said it's going to identify window of implantation. If you look at the publications, nowhere they said it beyond doubt identifies a window of implantation. It identifies for some people it is beneficial. The next thing is the original indication for ERA test was repeated implantation failure. But when they did the reanalysis of the original data, they excluded RF patients. And the test was designed for RFI patients, but the reanalysis of the data excluded RFI patients. So the original author's intention and the subsequent reanalysis are not exactly the same thing. That's what we should keep in mind. The third thing is there are few spelling mistakes in the graphics because I made these graphics to identify what genes and pathways does ERA identifies. It identifies cell proliferation and cell cycle regulation genes. It also identifies immune response and modulation regions. It also identifies cell signaling pathway like the calcium signaling, the WNT. It also identifies extracellular matrix remodeling, and to a certain extent, the hormone response genes to progesterone estrogen. And below you have some of the genes that are identified in this panel of 238 to 248 genes. But there is an important thing, what it does not identify. It does not identify embryo-induced endometrial changes, the relation of progesterone to the biopsy levels, the non-mRNA biomarkers, that is the microRNA, the protein, and the immune cell profiling, it misses. It misses the impact of microbiome on the endometrium, and also the biological fluctuation of window of implantation from cycle to cycle. These are some of the disadvantages of this test. It has certain advantages, but certain disadvantages, as shown in the two slides. From 2011 to 2023, close to 150,000 tests were done. But when we look at the studies that were presented, they don't even come to 3,000. If you look at the numbers in different studies, the amount of study is, some is less than 100, some are 500, 600. But if you really look at them, they're not coming into huge numbers. None of the studies are in thousands. Then what happens is there can be a statistical bias, there can be a performance bias, because pregnancy, IVF pregnancy is multifactorial, and there are a lot of confounding factors. Unless the studies are large and huge, you don't pick up the problem. The second thing is, when you look at a lot of meta-analysis in between, meta-analysis are analysis of somebody's studies which the author is taking as material methods, and they don't get the original data of the Excel sheets. They get what is written in the paper, that means after the reviewer comments and edited things. How often do the original authors get the original data set to do the meta-analysis? That's also a question to ponder. Then in that context, this is an opinion in 2023. Are there issues with our journal publications? Or are there quality issues in our own journals, so that we don't trust them? Because here is a test which was released in 2011, and in 2023 to 25, we are debating it's not useful. That means, did our journals fail us? That's also a question to ponder. Then in the reanalysis of the original study which was done, there again, they excluded RF and then they did the comparative studies. They validated error test in relation to standard transfer. They validated the estimated harm it does if it is adjusted. And the reanalysis has taken error test as a fact that it picks up receptivity and then questioned it. But nowhere in the scientific data you see that it is a test for window of implantation or window of receptivity. And then, as I shown in the thing, it tells us certain group of parameters. So the test is not complete, and it may be useful in a small subsegment of RIF patients, not for every patient. And that small subset has not yet been identified, is my opinion. So the same thing we are looking at when they did a transfer with and without error diagnosis, they found a similar thing. Then when they adjusted it, they found a lower pregnancy rate, saying negative implantation. So the augment when they're speaking about all these articles is only in specific to error test, but not every endometrial receptivity assay. That's one thing one should remember. So it is controversial. The predictive value is flawed, but also they're suggesting harmful clinical outcome. And it is unable to accurately identify window of implantation in every patient. And it is diagnosed as unproven and untested, and it's not correlated to actual receptivity or IVF success in every patient. And the original data is only for RF. These are the points one should remember when we are speaking endometrial receptivity assay. And when PET personalized embryo transfer is reduced as an increased birth rate, but who said it was designed for that? We in India were using it as a personalized embryo transfer, but the original indication was for RF. And more than that, the concept of RF has not been clearly defined in the last 15 years. In 2011, the global standards were two embryo transfers, in India 3 to 5 embryo transfers. In 2020, they moved to 1 embryo transfer. In India, we moved to 2 embryo transfers. So the number of embryo transfers, when you say 3 IVF attempts, the number of embryos vary. The definition itself is not has been standardized. On top of it, you are doing the study to assess a receptivity assay. These are some of the fallacies that are there. And most important thing is, you should look at endometrial receptivity assay as an area which needs further analysis, both in terms of genomics, that's the NGS, proteomics, secretomics, and metabolomics. And that's the future where it will answer the question. And genomics is just one aspect of the whole picture. And any variation of that gene can have a protein alteration and a metabolic alteration. That is what we are not studying. So endometrial receptive array at this moment is incomplete. And in the next 5 years, with the advent of NVIDIA has released a AGI related thing for biological pathways called EVO2. That is going to change the whole diagnostic field in biology, because it can give information in the live and that is not released commercially. And the turnaround time in which it does the test is in real time. That will change the whole field of reproductive medicine in the next 5 years. That's my opinion. I say that both the speakers have given their perspectives. Both are not wrong, but the facts are the test itself is wrong. The test itself was designed for recurrent implantation failure. On top of it, it was a conflict of interest by that group, which led to proliferation and then a disrepute for a beautiful test, is my personal opinion. I'm open for discussion.
Thank you so much, sir. Thank you so much for giving your insight about this whole study, because when it came with a big bang, it's like, everybody thought it's one, when the patient said do something, then everybody started doing it. And as you say, no, 150,000, more than so many endometrial receptivity array tests have been done. Then finally, even the small window, as Divyashi was telling, that point of implantation, we cannot identify. And we were like looking at hourly changes, 120 hours from the time of progesterone started. They used to start what time progesterone was started, what was the P4 value. So there are a lot of biological variations that we have been seen from one cycle to the another cycle, and extrapolating the result of one cycle with the same protocol to the next cycle, it can be difficult, because you would have used the same estrogen, same estradiol valrate the previous cycle. The endometrium would have become 8 millimeter even on day 9, day 10 itself. But for even during the ERA test cycle, it will take, maybe it will have taken another 2-3 days. So we do not know where are we, looking at in terms of timelines of doing the biopsy, the progesterone cutoff values, and the progesterone timings from P+5. So he says when it's a day 3 transfer, you do this. And disclaimer always, no, they say you repeat the test. they say it comes as pre-receptive or post-receptive. They don't want to take chances. They say you do a repeat test with a new protocol, new changed regimen, and then they say it's spending another thousands and thousands for that test. So finally, I mean, I know it has come up with a big dispute these days because of fact that, it could not stand the test of how ectopic pregnancies can be explained, how scar pregnancies can be explained. When you think of, we see so many ectopics. When we are looking at endometrium receptivity genes, and where is the tube having all these genes and the embryo going and getting implanted there? And we are having so many scar previous cesarean section, scar pregnancies. So none of these can be explained by the endometrial receptivity array test. And when the patient says, doctor, after 2 implantation or even after 1 implantation, they say do something. And when you know that you have a morphologically normal embryo sitting there in the fridge, and you want to do something to the endometrium, I think we are just, I mean, maybe it was as there's definitely been a commercial intent, and we have actually been overdoing. And when the controversy came about all these things about ectopic pregnancies, scar pregnancies, and the embryo being roaming around in the endometrial cavity fluid for 3 days and finding an optimal place to implant. So all these things have actually made us think twice or thrice, maybe 10 times before embarking on this test. Because first thing is, are we doing justification? Number 2, are we really worth the money that we are going to spend, make the patient spend on these things? So any question?
We forgot what it misses.
Yes.
We only looked at what it picks up.
Correct. Absolutely, sir. Absolutely. Completely agree with you. So
That's a fundamental small thing which we forgot.
Correct. Absolutely, sir. We thought it was like one end-all solution for endometrium. We say seed and the soil story. We keep telling the seed and soil story to the patient. We presume that we have good seeds we cryopreserve good seeds. Now let us look at the soil. But many times, we actually fail to look at the embryos because we do not know what the embryo's inherent genetic condition is. So any other questions from the
I congratulate Sweta and Divyasri for the wonderful presentations. They did a good job. I appreciate it.
Thank you so much.
sir.
Thank you, sir.
Thank you,
sir. Thank you so much.
Thank you so much. And
Because-
so I think, sorry, sir.
Because what happens is, as a debater, they did a good job.
Yes. So I
mean,
chose
I should be honest.
Yes, sir. Yes, sir. Thank you so much.
And they did not. They kept the data and defended their position. But ultimately, I should give a perspective from a different level of what we are missing in an error test.
Yes.
And then look at how they tell, because I've been to Valencia. They are the largest endometrial gene study bank in the world. In science, sometimes there are mistakes that happen when the company makes the decision. Valencia has an IVF chain, which is a company where the individuals are sometimes opinions are thrown away because a product can make a money. But a discredit goes to the other sometimes. We don't look at it from that point. And because what happens is, if you look at Human Proteome Project or HPO, Human Proteome Organization, the Valencian endometrial work is also listed there. But what happens is, sometimes a researcher may not have control on his data. The company he is working in sometimes has a control on how the data is projected. But sometimes we discredit the researcher as if he did not do the right thing. That's how we should look at that bigger picture.
True, sir.
But also the marketing is so robust that,
But,
as if ERA is everything is what they market. And if you see, even at the international forums, we don't see now, especially ERA being discussed so much at all. But still in India, we find that everyone, just because one IVF failed, okay, we'll do ERA. So that is something which should be, should be checked from
one thing is,
authorities like you.
with many years of experience, what happens is we should be truthful in a scientific forum, but avoid being an activist in real life, because scientific forum is for discussion. An activist is a different role, where we separate both the two. In a scientific forum is for area of discussion. And I feel the journals have failed us in the last 10 years. That's my opinion. Because because what happens, many studies have been published. But if you look at, they also know that at the same time, parallelly from 2014-15, there were parallel European groups were looking at different sets of genes in addition to these genes. And they said ERA test has certain limitations, and it is more progesterone driven group of genes, was their opinion, but they were more than that. But ultimately, when you look at the data from 2025, there are many pathways it misses it, and it's useful for a small subset of people, but that subset has never been identified in RIF.
Correct.
But I personally feel I didn't use it much, but I feel it has a role, but refinement will come with time.
Yes, definitely, sir. So we are having so many post-myomectomy, post-cesarean pregnancy. So I think I don't know how we are going to extrapolate the results, with so much of variations in the endometrium, the endometrial behavior itself from one pregnancy to another pregnancy. So I think we have to really agree to the fact that, science has its own limitations, and what we can presume or, convey to the patient, all fingers, we can only say fingers crossed at all times. So, and with that note, any questions from the audience? Sir and Divyashri and Shweta will be happy to answer. Sir will be very happy to answer your questions. Any questions from the audience? Thank you so much, sir. Anyway, in case if there are no questions, we'll wind up the session. But I really enjoyed the session because I always believe that, anything that needs to be, that comes into clinical practice needs very strong evidence. Whether the company person convinces or not, we have to be convinced ourselves, first of all. If we were the patient or we were the couple, will we get it done? Or we do it for something? It's going to make a major change in our management, or to make a major change in the results. So then we can go ahead, because, and to be frank, cost is definitely a factor for our patients. Each test costing 49,000 rupees is something, and doing it repeatedly, it's something which, already they're spending so much money on the treatment process as such. So on top of that, if we're going to make them spend for these kind of tests also, I think it's sometimes we just have to, I always say we'll do our best, and definitely we all our practice goes on few things like, science, support, spirituality, and we always believe in God also. So we let us do our bit scientifically, and then most of the time things will fall in place. As Divyashi very rightly said, see, many times you have so many embryos, one of the embryo will definitely go on implant. If that embryo is not implanting, maybe the next set of cohort or embryos, next set of embryos. So that is the first time when we have so many embryos, and I'm strongly believing single embryo transfer. So I feel like, the more number of embryos you have stored, you have, the back of my, you're kind of, okay, fine. She did not go through another collection cycle. So I strongly believe in single embryo transfer. So we have more numbers to FETs subsequently. And any other questions from the audience, or any other from the Divyashri, Shweta, you want to ask sir anything? Shweta?
Ma'am?
They did a good job, man.
Thank you, sir. Thank you, sir.
Thank you so much. It is really been this Vivaadham series has been very interesting for me because I do obstetrics, gynecology, fertility, it's on endoscopy. So I really enjoy this topic where we select one particular niche topic in then and talk the pros and cons and try to understand the nitty gritties of each and everything. Thank you so much, Dr. Shweta, Dr. Divyashree, Ramaraju sir. It's been a pleasure doing this. It's been a pleasure listening for the past 1 hour. Has been like very, why we have to keep asking why. Are we justified? Then, but
one of my first talk with the Obstetrics and Gynec Society of Madras was
Yeah.
when Madam Sachivama Reddy and Dr. Bhaskara sir was there.
Okay.
It was in 2000. It was
Okay.
in Russian Embassy auditorium.
Oh, here only.
Where I presented my XC data.
Oh.
That was in 2000. It was in the Russian Embassy auditorium.
Yeah, here only, sir. Thank you. That I know you have a long connection with Oxy, sir. We'll keep calling you quite often for our to enlighten us about about all the topics that you have been. We feel very honored and humble, to have you over.
I'm available anytime.
Oh, thank you so much, sir. Thank you so much. Thank you, everyone. On behalf of Oxy, I would like to convey my thanks to the speakers. Excellent job. And all the studies. Yeah, once again, Meena, you can take over, Meena.
Yeah. Vijaya ma'am is there? Vijaya ma'am.
Yeah, ma'am just left. Ma, she called me. She's left.
Okay. Okay, then we can conclude.
Yeah.
Thank
So
you. It was a wonderful session. Karpagam, Ramaraj sir, Divyashree and Shweta. Excellent session.
Thank you. And I thank Shri Events for the platform, everything. And we'll keep in touch. Definitely we'll keep in touch. Thank you so much, sir. Thank you, Shweta. And thank you, Divyashree.
Thank you, ma'am. Thank you, sir. Thank you, ma'am, for the opportunity.
Happy evening. Happy evening to all. Thank you.
Thank you.
Thank you.
We can take a group pic.
Yeah, I just took one. I just took with all the analysts also.
Yeah.
Okay, bye.
Bye.
Bye.